Okay. So, good evening, everyone, and good morning to Dr. Seetha. On behalf of YLM, I, Arjun Kumar Saha, welcomes you all to Sangath's monthly research webinar. As we know, today we have Dr. Seetha Ramanathan, who is an associate professor in the Department of Psychiatry and Behavioral Science in United States. She is also a medical director of State University of New York for Adult Psychiatric Child Clinic. She is also a divisional chief of maternal mental health and research director for suicide prevention. In addition to that, she also teaches medical students and residents in United States. She leads the implementation project called Zero Suicide Efforts at State University of New York and is also a co-investigator in NIMS grant that is examining the effectiveness of brief intervention for individuals who have attempted suicide. Today, she will be talking about suicide safer care and zero suicide implementation in Healthcare Institute. We will also have a question answer session after she completes her presentation. So over to you, Dr. Seetha. So let's start our presentation.
Okay. As I don't know who just introduced myself, but thank you. It's good morning here. We're just starting our day. And it's good evening to all of you. I'm going to share my presentations. Let me know if you are able to see the screen. Wrong slide. Can you see it? Are you all able to see the presentation?
Yes, we are able to see
Okay,
it.
great. Okay, so I'm going to actually talk about suicide safer care and zero suicide implementation in healthcare institutions. So I'm going to bring the example of Upstate Medical University, our university hospital, and what we did to implement suicide safer care, particularly zero suicide. So I'll begin with a brief background because it's a completely different setting, right? So I'm going to begin with a background and talk to you about this activity. It's an implementation research activity. So we'll start off with, I'm going to just give you an overview of what's happening in the United States. We'll narrow it down to New York State, Onondaga County, where we are located, and how we are at Upstate. So as you all know, suicide rates have been steadily going up. They started going down in the last, in 2018, 2019, and 2020. This was in the US. But then in 2020, we saw another rise. Now, the great thing is that it's not gone up very high, but we know 2020 numbers are not very accurate. We also don't know what 2021 looks like. This is when the pandemic started in the US, and March 2020 is when we went into a lockdown. So after that, we don't have, it's almost like a black hole. Where is the data on deaths by suicide and where's the data on deaths by overdose? We're hoping it'll come out soon. But so far, the CDC has said that it actually went up in 2020. There was a report that came out earlier that it may have gone down, but that's not really true. It actually went up, and this is in line with all pandemics. So deaths by suicide actually go up during the pandemic and in the years after the pandemics. So that's New York State, way in the top, really cold over here. And we live in this area called Onondaga County, which is 4 hours away from Canada. So this is the Canadian border over there. And it's we have these long gray winters, which last for around 5 to 6 months. And we are one of the snowiest cities in New York State. That's Syracuse. This is the county. The county has multiple cities, obviously. Now, this is why, this is what makes Onondaga County special. Not a great number to be, it's not a great number to be proud of, but we have among the highest rates of suicide, deaths by suicide in the state of New York. The state of New York overall is actually is actually a state that has one of the lowest rates of suicide, deaths by suicide in the country. It's among the bottom. It's either the bottom or maybe number 2 after California. But Onondaga County, unfortunately, it's pretty high. Now, this is only deaths by suicide. We haven't counted deaths by overdose because it's very hard, as you all know, it's very hard to figure out if it is a death by, it's an accidental overdose or was an intentional overdose. So we're at 11.7, and we've consistently, except for 2017 when we were lower than the state average, we've always been higher. And the Suicide Prevention Office likes to call it call our county a Goldilocks county, and that's why we were picked to implement this project. Again, when the director explained the reason, it was not the greatest reason, but the explanation was this is a small enough county to implement a large project, but it also has a high rate, so we can maybe show a difference if we do a systematic implementation of zero suicide. All right. Why do we have to? What is the role of healthcare institutions in suicide prevention? A lot of times when we talk about suicide prevention, we're talking about individual patients, individual people, or we're talking about the communities, we're talking about schools. But what role do healthcare institutions play? And why should we care about the quality of service that's delivered in healthcare institutions? These are just some numbers that I pulled up. It's 45%. This is data again from the US. I don't know of data from the rest of the world. 45% individuals who died by suicide saw their primary care physician in the last month. 80%, that's almost 100, it's almost all of them, right, saw their primary care physician within the last year. The primary care physician is also is essentially a general practitioner over here. It's like you go to this individual for your annual checkups and when you fall sick. And 18 to 40% actually saw them within the last week, and that number changes. One of them is 45. Now, we also know, so we use this when we train primary care physicians in suicide prevention. We also know that 50% people who have died by suicide have a treatable mental illness. At one point in time, we thought it was 80%, but now we know it's 50%. We don't know about the other 50%. Why? We don't know the reasons why they die, but we know that at least 50% deaths are because of can be associated, can be correlate, can be have been identified as being as having a treatable mental illness. Now, I'm going to start off. I'm not going to talk about a lot about primary care physician because our implementation got very delayed. So I'm going to talk about implementation in behavioral health settings. It's strange I'm going to talk about that because one would think that if someone comes to a psychiatric, an inpatient behavioral health unit or an outpatient behavioral health setting, we would be delivering suicide safer care, but unfortunately we were not doing it as well as we could have. Now I'm going to focus on our inpatient units. What we know is that discharge from an inpatient, the first 3 months following the discharge, is one of the highest risk period for suicide. So a lot of suicide completions happen in the first 3 months following the discharge. So it gives us a great place to intervene. Can we have somebody in the hospital 24/7? We have them in the hospital. Can we make a change in the quality of care so that the risk during the post-discharge period is mitigated? Well, let's see if we were able to do it. So, all right. So now, what strategies have health systems used? I've only described two over here. One was the depression care model by Henry Ford. It actually evolved into what is called a zero suicide. Zero suicide is essentially, so it's an evidence-based model. So we didn't have to create the evidence. We just took an evidence-based model. It's the same model that I described was started by Henry Ford Hospital. So Ed Coffey was the one who started this in Henry Ford. Henry Ford is one of the leading institutions for quality of services in the United States. And what they did was they essentially said, across the system, anybody who touches the hospital system, anybody who comes for any kind of services is going to be screened for suicide, and we are going to give them appropriate care. And they demonstrated a significant reduction in their suicide attempts and deaths by suicide in people getting services in their hospital system. This was again done. They repeated this in New York State, but that time they did it with all the behavioral health settings. So it's a little different in the US. We don't have a public health system like Australia and the UK, but we do have a version of the public health system, which is run by the State Office of Mental Health. So a number of clinics are licensed and operated by the State Office of Mental Health, and that is our small watered down version of a public mental health system, but it is also a system which can implement. Because if somebody at the top of the state says, hey, we are going to implement this policy and you're all going to screen, it's easy. We all have to screen. So they did this in the Office of Mental Health licensed clinics, and they found that they were able to reduce deaths by suicide. Again, deaths by suicide in the state of New York are actually, so it's a, I would say when we get the information, it's pretty robust. It goes through the coroner's office. There is suicide attempts have to be logged and tracked in a database with the state. Getting access to the system is a pain, but as the state has obviously the data, and if you have a collaboration with the state, you can get the data. And more recently, it was actually implemented in Australia as well, and they found that systematically addressing providing suicide safer care, there are elements to it, and I will talk about it, can reduce deaths by suicide. All right, so the core premise of zero suicide is that suicide deaths for people under care can be prevented. It is systematic integration of suicide prevention across the health system, not just behavioral health. It's also primary care. It's essentially everybody. If you talk about primary care, OBGYN, you can talk about surgery. I mean, it's difficult to convince a surgeon to do suicide safer care, but can you ask that question, are you suicidal? So it's across the system, and it's essentially a systematic implementation of screening, identification, evidence-based interventions, and then monitoring of those who are at high elevated risk. So we stratify risk as well. All right, so these are the 7 elements of zero suicide. I'm going to go in more detail over here. Lead is leadership-driven, sustainability, and in many ways, the leadership can then change policies. We then train our workforce to systematically identify, screen, and stratify suicide risk. You engage the patient in care. Then you provide effective evidence-based methods, and that's important, evidence-based treatments. I have to ask the state, do you know of what are the evidence-based treatments? We are all not trained in it, even though we implemented zero suicide, we are not trained in all of it. Transition of care, where we provide follow-up calls and improve, keep in a continuous process of improvement, which is data-driven across the system. So we think that if we were trained in the zero suicide model, and essentially we believe that, we started believing that, I think we still believe that if we implement all these 7 steps, we will be able to improve quality of care that we deliver in our system. So doing this is obviously very difficult. Everything needs some funding, and thankfully the state took the leadership over here. We have a great, like I said, in New York State, we have a great suicide prevention office. The director is a psychiatrist who I think even dreams of suicide prevention. So the team pulled together various institutions across New York State and picked the county. So I bring up the county because it's not just Upstate, which is a part of the county, but they decided that this county is going to become a zero suicide safety net, and we are going to try and reduce deaths by suicide in this county by 20%. Ambitious goal, really ambitious. This was in 2018. We did not expect COVID and the pandemic and financial crisis to happen, but but we said we'll forge ahead with this, right? So we pulled together institutions, and that was a story in itself, trying to pull together multiple institutions. We have 3 big hospital systems. Now the biggest one is Upstate. So if you get Upstate in your system, you've covered a lot of them. The second one was St. Joe's and Krause, and then we had these smaller behavioral health organizations. And then the next step was to bring in the primary care physicians as well. But I would say everything was pulled together. And in 2017, they were awarded a SAMHSA grant. SAMHSA is an implementation funder. It's the federal funding agency that implements federal implementation grants. But this was only for people above the age of 25. The state followed up and got a second grant, which helped us implement the same model in individuals from 13 to 25. So we're now able to cover 13 and above. we are also, at that time, we were not seeing the trends that we are seeing now, where we have more younger people coming in. But I guess it prepared us for it, right? Now, the first year was training. Now, even though the grant came in, was announced in 2017, 2018 was the launch. And then we said we'll implement it. It was supposed to be a staged implementation with behavioral health, emergency departments, and primary care practices. But as you all know, in 2020, we all went into a lockdown, so everything kind of shut down. So we're still in the process of implementing in the emergency department and primary care practices. There's not much data available on that. But I can talk about the inpatient and outpatient behavioral health systems. So this is Upstate Medical University. We have two units. We have two hospital systems, two hospitals under a broad umbrella. One is the downtown campus, and the second one is the beautiful greenery is our community general campus, which is not in downtown. Whereas the downtown campus is basically a concrete jungle, right? And the second one is an outpatient behavioral health setting, which is a much smaller setting, around 300 patients. But the difference in this setting is that it is a high-risk program. It is the county's only comprehensive dialectical behavior therapy program. So most of the patients seen here are supposed to be high risk, but I'll show you data over there, which talk about how we screen and what our numbers look like. It was also the county's level 3 trauma unit, which means it's the highest level of trauma, and we get patients from across the all the way to Pennsylvania border and up to the Canadian border, okay, and both sides as well. So it's a big catchment area. Now, we had very simple outcomes that we were looking for. We only wanted to see if we can improve the delivery of care for suicidal patients. The state's outcome was obviously much more ambitious. I want to say grandiose, but that'll make it very delusional. That's not the goal. I don't think it was grandiose. It was very ambitious, and they were looking for a 20% reduction. We don't have that data yet. We don't know if we did it, if we were able to get to that 20% reduction. Again, I think because I sit on the number of committees, I don't think we got there, and I think it could have been because of the pandemic. We don't know that. All right, so now we started off with a big launch. I'm sorry, the picture did not come through. Big launch, that's what the state started off with. So in June 2018, all the behavioral health settings, all the leaders of all the big institutions and the smaller institutions got together for what was called as the big launch, the leadership meet, and that's where the project was announced in the county. There were a few other sites across the state, but a lot of them dropped off. So at the towards the end, there were 3 or 4 big hospital-wide institutions surviving in this model. We were one of 4 who were able to continue with zero suicide. And actually, I think we were able to grow our suicide prevention system. So the state brought together all the teams, all the leaders, and it was a 2-day event where a lot of discussion happened, with a lot of collaboration. How do we keep this? How do we make this firstly, how do we launch this program? How do we implement this program? And how do we learn from each other? Because we were in the same county. Okay, so the first step was staff training. I cannot believe, I cannot describe how difficult this was. The staff was trained in certain modules. And one would think that if you were getting training, you would go for it, right? Now, it was not that easy because the staff were already getting multiple trainings. And here we're saying, hey, you are going to learn how to screen and stratify risk and also provide some simple interventions. It was not easy to get them to do that. So NIASAC is essentially what the whole initiative is called, New Yorkers Advancing Suicide Safer Care. Really catchy title. We want that symbolism, right? In any implementation research. Anyway, so we had multiple training modules that were prepared to us by some of the experts that the state had identified. So we had patient and family engagement, the Columbia Suicide Severity Rating Scale, a risk assessment, now a safety planning. And I stress safety planning because one of the things in our unit, and I don't know if it's the same in India, I don't remember, is our length of stay, how long a patient stays in the hospital. It's pretty brief, 5 to 7 days. Patients come in, they're literally evaluated, and a discharge plan is made. You are going to go out. That's the length of stay. So there was a lot of emphasis laid on a good quality safety plan. It was called the brief and mighty intervention. If we are able to give the patients, engage the patients in a high quality safety plan, we have, I guess we've reached the base camp of Everest. We still have to climb a lot more, but we've done a good job, was the idea. But we also taught them about means reduction. We taught them how to do means reduction. As you all know, 50% deaths in the US, perhaps you don't know, but 50% deaths in the US are because of firearms. So we spoke to them about, we would teach them about means reduction. New York State has a special act called a SAFE Act. It's essentially reporting our patients who are struggling with suicidal and homicidal ideation to the state, and the law enforcement department, which is the police, will go into the patient's homes, and get all the guns they have. And at the same, the information is also sent to the gun shop owners, and so they have a list. There's a database. The gun shop owners have to run the names by the database, and they can stop the sale of guns. Now, that doesn't mean the patients don't have access to illegal guns, but that was one provision that was put in place as well. Another thing we taught our staff was foreseeable changes. This is a very interesting concept, and I've seen it maybe in one or two patients where I do foreseeable changes on a regular basis in my clinical practice, but in one or two patients, I was able to say, if I hadn't done foreseeable changes, I would not have been able to prevent suicide in this person. Foreseeable changes is basically speaking with the patient, asking the patient to identify 2 changes in their future that they think can change their suicidality. So what are the 2 things that can happen in your life that can make you more suicidal? You're not saying that you will never do this, but what are the 2 things that can happen that can change it? And then we work with the patient using that, using those foreseeable changes. The last one is a comprehensive risk assessment, which is risk and protective factors, and then modifiable risks, and how do you modify the modifiable risk. So this was a training. Now I spoke about these trainings in 2 minutes, but the staff had to go through around 3 or 4 hours of this training. Easy for psychiatrists, residents, and trainees to do, but very difficult for nursing staff to engage in, right? Because they're on their feet and they're mandated for overtime and all that stuff, and they just can't find the time to do this. So then what we said was, we are not getting our completion rates. We were trying to get to 75% completion rate to achieve this goal. We said this is not working out because we were getting 40-50%. Now we were able to, what we did was we used our data to see which particular team members, a set of team members is not able to do it, and trainings were tailored. We offered them incentives. We were on their case. We were sending them repeated emails, or we would go and speak to them. And we would also engage them, saying, what do you think? What is the problem? One of the problems they identified was like, I have to go to another different website. And that website is not easy to navigate. Can we get them into our own learning management system? So we worked on that. And the bureaucracy involved in that was not easy. So we said, okay, we'll try and get it into Upstate's own learning management system. It was called Blackboard at that time. So, and we had to go to another website. So initially we said, put the link in LMS and all that stuff. So we had to navigate that, but I think we got to 70%. It was a stretch, but we did get to 75%. All right. So what I'm going to discuss is, after the training, what were we want to see numbers. What did you all achieve, right? After all this effort, $3.5 million for 5 years, what did you all achieve? So I'm going to talk about a few outcomes. I guess in implementation research, it's a lot of implementation issues and some data, but I'm going to talk about some outcomes that we were able to that I was able to pull up. Okay, so I'm going to talk about, of the 7 elements of zero suicide, I'm going to talk about how did we do with identifying, how did we do with engagement, treatment, and transition. Okay, so with identification, I'm going to talk about, did we do a good job with screening? Were we able to identify and stratify our high-risk patients? Were we able to engage them in treatment provision? Now that's a tricky one, right? All of you know that engagement is we can define it very differently. I'm going to talk about just were they able to participate in certain simple interventions that we used. Okay. All right, so on our inpatient units, this was our screening rate. We saw a total of 15, 16 patients. So roughly over the 3 years, we've been seeing around 1,000 patients. Now, sorry about that. Now 2022 ended in September, so the numbers are much smaller. But we screened, we didn't get 100% screening rate. Even in our inpatient units, we should have got 100%, but we were at 90% and above, which is great. But our positive screens were pretty high, as you can see. Around 75 to 80% in our third year actually screened positive for high risk for suicide. That's a very high number, and we know because we could compare numbers across the state. This is very high. On an average in an inpatient unit, you're seeing around 40%. So for some reason, Upstate was screening at very high rates, which means we are going to struggle to give our interventions, right? Because interventions for high risk patients is going to be at a different level. We continue to retain, and I think it's gone up. And then we concluded, I'll show you that we try to figure out if this is a right number and all that stuff. And we concluded this is the correct number. We are screening correctly and accurately, and we are seeing an extremely high number of high risk patients. So that number was correct. Now, when I say high risk, this is the Columbia Suicide Severity Rating Scale, and we are fortunate that we have a great electronic records team that worked with us. So they were actually involved in the implementation from the beginning. They built it into the system, and we were able to identify. The staff didn't have to do much, but Epic, which is our EMR, would actually tell them if the patient is high risk or moderate risk. So the orange and the red ones were the high risk patients, and the yellow ones are the low risk. The orange is moderate, but we club them in the high risk bucket. Again, somebody could have asked this question: hey, what if you remove the moderate risk? Do you think you would have had a number that was more, and that was small enough for you to implement the next few strategies? I don't know the answer to the question because everyone decided to go with this and said we'll do this. So as you can see, the lines are parallel, just graphical representation of our screening and positive screens. They were across the 3 years. I think we maintained it. We maintained our screening. We could have done better, but we did not. But we didn't go down, and we maintained it. And these are the various interventions we provided. We have a crisis line here in the US. Initially, it was a big number that we would give. Now it's 988. So we would give all our patients crisis line information on crisis line. We would try to give them information. It was called universal precautions, that everybody is at risk for suicide. There's some risk for suicide, and what can you do if that risk increases? We would give them the information and a brief and mighty intervention, which was a safety plan. The last one was called structured follow-up phone calls. Now, some people have labeled it as transition. I also label it as treatment because a structured follow-up phone call was actually done by another agency because we could not find staff to do it. Structured follow-up phone calls is a set of phone calls which were made to the patients after discharge, primarily to go over their safety plan and to motivate them to reach out to outpatient follow-up or understand barriers and help them navigate that, right? So that was structured follow-up phone calls. But we were not able to do that in our system, so we outsourced it to another system. So we would, imagine, take a consent form, fax it across, lots of barriers, lots of places where patients can fall through the cracks. Right, but look at that, 99% crisis line, everyone got it. Now it's very simple. All we did was we built it into Epic, and the discharge information printed out, crisis line and the patients. And during discharge, staff actually sits with the patient, goes through discharge instructions, and that time they did the crisis line. This is the number you can call if you struggle with anything, if you start feeling suicidal in the future. Universal precautions, we didn't do a great job, only 50%, but and safety plans started, we began with a bang, 93%, and then even during the pandemic, we were very high, and then we went down, and now we are trying to, go up. We're trying to do better again, but I still don't think we are doing it's not a great job, right? Now, what we did was we shifted our focus to the structured follow-up phone calls. Together, the intervention of safety planning and structured follow-up phone calls is called Safety Planning Plus, and it's been shown in studies to be an effective method for prevention. So we said, let's try and focus on safety plan on structured follow-up phone calls, and we did a lot of stuff, and managed to increase it by 10%. It doesn't seem like a great number, but for us it was a huge achievement that we did it, kind of thing. So anyway, so this were the trends. I can see some things in the chat, but I'm not able to monitor it. I don't know what it is, so maybe we can get it. Maybe somebody else can help me out. Okay, feel free to stop me and ask questions. Somebody else can help me out with those chat questions. Yeah. Or you can just unmute and say and ask questions as well. So this is how trends look like. Sorry, go ahead.
Seetha, don't worry about that. We'll take questions at the end.
Okay, great. Thank you. So this is just a graphical representation. Pictures speak more than numbers, but it may not seem like this, but the thing that I'm most proud of is that we increased our structured follow-up phone calls. All right, so these were the outpatient trends. Again, remember the numbers are small. These are the new patients that we saw, 120, 118, and 130. It's a much smaller program. Again, here also, I'm surprised, I'm shocked that we were not able to get 100% screen rate. And I'm shocked because obviously I'm the medical director of the clinic, and I had one of the best quality QI person working on this project. So I think this number is not wrong. I still think it's 100%. But you can see, even though we were a comprehensive high-risk program, we did not see our positive screens were much lower. I think we're also because I mean, my own, again, I don't know how to prove this, is that when you have a high-risk program, you have a high degree, you're more likely to tolerate risk. And we also dropped the moderate risk people. It was only the high-risk people that we were calculating as high risk over here. Again, not standardized across the systems, but I just think that they were more, they could, for them, you really have to be high risk to meet the high risk positive screen. But again, this was our trend, even despite a high risk program. All right, so now to summarize, I'm just going to summarize what we've done so far. Did we do a good job with the 7 elements of zero suicide? We involved leadership across all levels. I think if leadership was not involved, we would not have been able to grow zero suicide across the system. And you will see that zero suicide has actually grown across the system, and we continue to keep getting funding from multiple sources. So it's not just, we began with one leader in our system, which was our chair, and now we have multiple leaders in the system who are taking on zero suicide and growing it within their departments. So I think we did a good job there. Could we have done? Could we do better? Should we? I'm sure we can, but we didn't fail. We didn't stop zero suicide. We said we want to improve quality of care. Training. We still struggle to keep up with 75% training rates, but we then incorporated training into suicide safer care training into all our curricula. So all our residents, all our trainees get trained in zero suicide. We also have included the suicide safer care in our onboarding. So when we onboard new staff, we were able to include that. Again, we had to cut down. It was a much pared down curriculum, but we are able to train most of them. Screening and identification, as you could see, we still we should be at 100%, but 90% we will take it. So we're at 90%. We continue with the 90%. Engagement and treatment, despite pandemic related, and I can talk about, I'll give you the challenges we faced, but despite those pandemic related issues, we maintained a high rate of safety planning. I can't tell you about whether we did a good job with the quality, but we maintained a high rate of safety planning. Treatment and transition. So structured follow-up phone calls along with safety planning actually becomes an intervention. So I'm going to pull it under treatment. our structured follow-up referrals started increasing. We went up from 12 to 22%. So that was good. So we did a little better. Now, treatment modality. So when Zero Suicide talks about treatment, it's essentially providing evidence-based treatment for suicide prevention. This and they have a list. It's dialectical behavior therapy, cognitive behavior therapy for suicide prevention. We have one more called attempted suicide short intervention program, and then at Upstate we have our own in-house. It was created within our system called dynamic deconstructive psychotherapy. And we have, like I said, we have a DBT program. At one point in time we thought we'll shut it down, but leadership came together and said, no, we have to keep it going. So that's still going on. We don't do CBT for suicide prevention, but we are one of the only systems that's testing us. We also have DDP, like I said. So we have a high-risk program, and that keeps growing. So I think we're doing a good job with treatment as well. And we continue to monitor data. Now, obviously, without funding sustainability, it'll be interesting to see how we keep doing this, but we continue to monitor data and give feedback. But more than what we also did was the last year, the final year of the grant in 2022, we shifted from a systemic data collection to individual department data collection. So each unit was said, you guys monitor it yourself. So we worked on that in the last year of our grant. Hopefully they're still doing it. I'll get to know the end of this year, if we are still doing what we are supposed to do. All right, now what are the challenges we faced? I mentioned that the high positive screens, which means it's tricky to deliver targeted interventions because now you're doing interventions across the board. If I have a 90% high positive screen rate, then I am pretty much giving these targeted interventions for 90% people. So that becomes a little, it's a challenge. The next one is the transition, the post-discharge period, the high-risk period. It continues to be a challenge. And now we are testing out a new model. Can we do a bridge clinic or a transition clinic? The second one, as I mentioned, a structured follow-up phone calls was actually outsourced. So we are getting a consent form, faxing it across and all that stuff. And we set out to understand the reasons why people are refusing and all that stuff. And we started working on those. But another question that came up was, what if our system starts doing it itself? So that's another reason for the transition of bridge clinic. It's stuck, it's in limbo because we don't have funding over here, but we are working on a pilot project there. So what happened during COVID? So it was important for us to understand why we are not able to get our training rates high. During COVID, all resources where New York State was really hit very badly in March, all our resources were just shifted towards the emergency department and taking care of COVID positive patients. It was chaos. It was just I think it was just a blessing that our inpatient units kept working. But you can imagine that staffing went down pretty markedly, pretty remarkably there. Our residents got diverted, physicians were diverted, nurses were diverted. So and I actually looked at the data to see how many people showed up in the emergency department. The number of people showing up in the emergency departments for behavioral health issues also went down pretty significantly. So we struggled with staffing issues. Now, one would think after COVID, everything staffing would come back to normal. It did not. We're still struggling with staffing issues. In fact, at one point in time, our units were cut down from 48. We went down to 35 and then 30, and there was a risk of one unit getting shut down. There was a vaccine mandate that came up, which some staff decided they're going to leave. People started falling sick, and in general, after the pandemic, healthcare staffing struggled. We also started seeing burnout and changes in morale. We would have float staff coming in, so our staff was not being adequately trained. But it was really exciting, and so the one set of staff members that we did not we really said we should not stress them out at this point in time was our nursing staff. It was a significant shortage. It was really exciting to see that last year, one of the nursing team leaders reached out saying, can I get my nurses trained in this model? Can you send us the appropriate modules for my nursing staff? Well, that was great. There was a new leader coming on board, and she was like, I need to train my staff. I think we're at a place where we can do it. So hopefully we are picking up again. What we did was, like I said, we leveraged our app. So when we started seeing all these staffing issues, we said, well, we have the state-of-the-art electronic medical record. Can we work with our Epic teams who are all working from home? And they did a fantastic job. Can we work with you all to try and try and take over a lot of the manual work? So can Epic fax the consent forms? Can Epic print out stuff for our patients? So we leveraged our EMR, and I'm so proud of our Epic team. They really did a good job with that. In fact, when we were wrapping up in 2022, Epic came up with this initiative called, this is the Epic itself, came up with an initiative called Saving Lives Initiative. And one of them was their suicide prevention module. And when they demonstrated the suicide prevention module, our Epic team, our in-house Epic team said, we've done all that and we did a better job at this than you. So that was really good to hear. And this was actually endorsed by the Suicide Prevention Office. It was really wonderful to hear and really proud of that team too. They jumped right in. Obviously our leadership was involved. We gave regular data-driven feedback to our team leaders, and we worked with our staff. So those are the strategies we used. Now, I did mention quality of safety plans. One of the questions that came up was like, great, yeah, you're all, Epic is helping you do the safety plan, but are you really doing a safety plan? Are you checking the box, or are you just checking the box? So we did a random audit of safety plans, and we found that we were good 80% of the times, but we still wanted to increase it 20%, and we provided training to the individual folks. So that was done over pizza. It was a pizza training session that was done. Again, we had staff turnover, social workers also left. So the social work leader actually jumped in and said, I'll take over this. And I haven't done a repeat safety audit. Maybe we should do it, but and I think we have a project that will do it next year. But we did try. We did see if we were actually delivering good quality safety plans. So what are our next steps? We said we'll check in with staff. We'll check in with our patients. Did this help you? We will address transitions of care. And then now we're going to go to the implementation in the ED and primary care physicians. Obviously, we have to address healthcare worker wellness and burnout. And we are now working on trying to leverage concepts from behavioral economics to improve screening rates. And this is in the planning state. We still have to get the video to be done. I'm going to show you some prelim data on that. This was staff follow-up. This was staff confidence. As you can see, in 2022, most of our numbers went down. Staff was not very confident. But again, staff in 2018 is different from the staff in 2022. We have changes in staffing. So we have to obviously train them a little bit more. This was our preliminary data from the emergency department. Our emergencies department sees around 10,000 patients a year. January to March, this was last year, January to March, we saw how many people were being screened, or actually it was non-screening. How many patients presenting to the emergency department were not being screened? Obviously, it was a high. It was around 50. I want to flip the numbers. I should remember the numbers more. It was higher. 37% were being screened. So around 63 were not being screened. So the only intervention over here was we engaged leadership, and the number went down. So the non-screening number went down to around 46%. So we had a leadership meeting yesterday, and I was so proud. I was like, the only intervention you did was you got involved in this, and you lowered the non-screening rates. They don't do a structured screening. They only ask a few questions, but you can see both questions and non-screening rates actually went down just by leadership involvement. I haven't covered some other sections, but these are the other initiatives that are going on under this project. We have the adolescent unit that it's becoming increasingly more important to screen adolescents now. We are seeing children as young as 8 years of age in our emergency departments presenting with suicidal ideation. Makes me a little worried. I have a young kid. Makes me worried what's happening in the schools. But we have the same initiative in the adolescent units. We have an NIMH trial. We have 2 other initiatives called, one is Jasper Health, which is an AI-driven platform that is being provided to patients presenting to the emergency department. So it does their screening, provides interventions, offers a peer support and all that stuff through Jasper, through the platform. And the last one is a youth nominated support team for adolescents presenting to our adolescent unit with suicidal ideation. So essentially the youth identify a support team outside of their parent, maybe even their parents, outside of the hospital system, and those people are trained in suicide prevention that we can offer to, that we can train lay people in. So those are some other initiatives that are being again, no data on any of them because they've just been launched. So I'm going to stop, and I always think we have not met our outcomes, what we set out to achieve, but I'd like to hear from you all if we improved, if we've done a good job, and what else can we do to do better. So I'm going to stop and take questions. Maybe I just overwhelmed everybody. Okay, Madhu.
I mean, first of all, really like fantastic work. Like it's really interesting, really ambitious. And congratulations to you and your team for actually sustaining this during COVID. I mean, having worked in a health system myself during this time, I mean, it was just chaos. So, the fact that you were able to really dole out any kind of work to prevent suicide when, for example, in India, a lot of the hospitals shut down and became COVID. Sorry, that's my son. So, in India, a lot of the hospitals literally shut down and basically COVID took over. So, really hats off to you. And yes, I know, I appreciate the fact that you're always trying to improve, but 90% screening rate, I mean, that's fantastic, okay? You really can't do better than that. So, I mean, really, congratulations to you. My question really is, I mean, I love the idea of having an evidence-based kind of model that involves the whole system, right? Especially emergency, right? Because a lot of people with suicide attempts come to emergency settings. But okay, Seetha, my son is crying. I'm just going to get back to you in 2 minutes. Yeah. Yeah.
As we wait for her, any other questions?
Let's take some other questions. So if anyone has, please go ahead. Suhas, if you're talking, we're unable to hear you. So can you?
Yeah, can you hear me?
Yeah, we can hear you. Please go ahead.
So, Seetha, thank you so much. This is a really wonderful session, and thank you so much for putting this together. So actually I'm a counselor over here, and we are working closely with the people with suicidal ideation and all with the depression. So I would like to ask you, can you go back to the slides, please? I don't know the number. The questionnaire, what you are asking is that categories of mild, moderate, or severe. Can you go back to the slide, please? The question
you're talking about this. Yeah, I think you're talking about the suicide safety screener, right? Yeah, I'll show it to you.
Yeah. On the slide number 23. Yeah. Right.
Yeah, so it's called the Columbia Suicide Safety Screener. I mean, it's got a much bigger name. But what we now in primary care settings, what we are actually doing is so like I said, our work with the primary care settings, now this is obviously a very, to us, it's actually a questionnaire that's being promoted across New York State. So in primary care settings, so there's some really nice videos where a police officer is asking the same questions to a suicidal patient. It can be done by anybody. So in primary care settings, what we are doing is we're using the PHQ-9. I don't know if you use the PHQ-9, but question 9 of PHQ-9 inquires into suicidality. Now, if that is marked a yes, if the patient says yes to question 9, it cascades into the Columbia screener. So we want to know what is the severity of suicidality. So you can see the yellow over here is just passive suicidal ideation. Like, have you wished you were dead or wished you could go to sleep and not wake up? They're not actively suicidal. And then you go to the next question, but you don't stop there. You go to the next question. Have you actually had any thoughts of killing yourself? That's active suicidal ideation. So now you're entering the realm of active suicidal ideation. This patient it's not just, I wish I could just go to sleep. Now, what they are saying is if yes to question 2, then ask questions 3, 4, and 5. I would say don't do that. I would still go to 3, 4, and 5. I would scrap that out, and that's what we train everybody. Go ask all questions systematically because you still want to explore a little bit more, especially if question 9 your screener is positive. So if the patient says no to 2, I would say still go and ask, have you been thinking about how you might do this, how you might end your life? And have you had any thoughts and some intention of acting? So what we train our folks is like, don't stop with just that. Just go to the next few questions is what we train them. Obviously, you have to ask it in a sensitive way, and non-judgmental way. So that's what we've been training our staff in. But again, we are a behavioral health unit, right? So by the time patients come to us, they're already high. Just because in a behavioral health setting, you're on already high risk kind of thing. So that's a Columbia screener. It's being promoted across it. Now there are a few other screeners. If you look at NIMH, they have the ASQ. And that's another screening tool that they are using. But I don't know if you paid attention. Columbia is a school in New York State, so that's why. And we are in New York State, so we go with Columbia. It's one of the most. It's a tool that's being promoted everywhere.
Okay, fine. Thank you so much for the clarification. So actually, I had a question that, because we use a PHQ-9 and we do have a specific score for that. So based on the patient responses, we add the scores and we categorize them like the mild, moderate, or severe. So do you ask the frequency? I mean that top of this thing you mentioned that the month of the days, right? Something like that. But are you asking them the frequency? How frequently they're getting the thoughts and
No, so we don't ask that at all. So now with the PHQ-9, so there are two things that we do here in the state. There's PHQ-9, but we don't go by, obviously it like you said, it categorizes mild, moderate, and severe. But at any point in time, irrespective of whether it's mild or moderate or severe, if question 9 is positive, then it triggers an inquiry into more suicidality. The second one we've been doing, because our primary care physicians are very busy, is we actually ask them to do PHQ-2. Just ask those 2 PHQ-2 questions, but add a third question. Just asking people, do you feel like do you feel like life is not worth living? So we're just asking people, can you just ask that question? That's all. And then if you feel too overwhelmed, just pass it along to the behavioral health system. So that's what we've been doing, just to make sure that everybody who is touching the system asks that question.
Okay, thank you so much.
Yeah, you're welcome.
Yes, Madhu, you can go ahead. Still not there? Okay, anyone else, please?
Sorry, Seetha, can I continue with my question?
Yeah, go ahead.
I was just going to ask you, what is your logic for wanting to involve, the entire health system? I mean, I really admire that, but would it not have been more cost effective to just place this within the primary healthcare provider system? Because given that 80%, I mean, 80% is a huge number. If you've got 80% of those who've completed suicide having access to primary healthcare provider in the last 12 months, I mean, would it not have just been easier to do that? Do you have any data on what percentage of people had accessed other parts of the health system?
Yeah, I think it's a great question. No, I don't intend to involve all the healthcare system at all. We are involving primary care physicians. So only the behavioral, so the way it was envisioned was before we go to the primary care physicians and to the emergency departments, we have to improve capacity in the behavioral health setting. So like I said, the impression is always like behavioral health settings will do a good job, but we were not doing a great job. So and despite the congratulations on the 90% screening rates, I still think we can do a better job with the other stuff. So our next step is to involve the primary care physicians, and we started working with them and the emergency departments. Now there are some parts of the healthcare system that should be involved. for example, our oncology, our cancer center should be involved. They should be screening their patients for suicidality. There are some patients, some groups like the pain clinic, they should be involved because we know those areas are. So when I say include all parts of the health system, they should at least ask that question. So we are doing it a different way. So what we did was we started looking at, we've been talking about healthcare suicides, not screening for suicide, not just in your patients, but among yourselves and your colleagues. So what we're trying to do is educate the healthcare system about the importance of just suicide, and evaluating for yourself and your colleagues. And then we add this, and you always do this for your patients. Why don't you do it for yourself and your colleagues? But you can imagine a patient who's got a recent diagnosis of cancer, high risk of suicide. They're not, and not everybody has a primary care physician. So you still want a lot of people. And this is where a suicide fatality review committee comes into play. So it's another committee which we haven't discussed over here. It's not part of the zero suicide system, but it's similar to the child fatality review, where a group of people stakeholders come together and review deaths by suicide through the coroner's office. And we look at what the touch points are. And one of the touch points we found was other parts of the health system. One was the cancer center. So can we educate our cancer center? You are a high risk period. Can we educate our pain clinic? You are a high risk period, kind of thing. So we are waiting for the results from the suicide fatality review so that we can then do a targeted approach. But that being said, it's available on Epic now. We just rolled it out to everybody. It's available in Epic. Let's see if we can. It's a low hanging fruit. Let's see how much we can improve.
Okay, thanks.
I want a perfect suicide safer care system, like Mother. I want to
Clearly,
lower the rates.
Clearly, 80% is not good enough.
Yeah, no, I want the
90%
perfect system.
90% is not good enough. Now 80% is not good. No,
Yeah.
really, I mean, great. It does make sense to involve the entire health system. You've got,
Yeah. So but it's a
patients with
stepwise.
comorbidities like cancer and stuff. They are highly, they are.
Yeah. It's a stepwise approach. There is a question, how challenging is it to screen patients with severe mental health issues like suicidality? Because here in the Indian context, the awareness about mental health and its problems are still like, oh, it's there over here as well. It's over here as well. People don't want to acknowledge. So let me also point out another barrier over here in the US. Some patients do not want to say yes, that I am feeling suicidal, because here in the US, physicians have the authority to hospitalize you without your permissions. It's almost like I am sending you to prison, right? So I can take away the rights of a patient and say, you are suicidal, you are not safe. So I can take away your rights and send you to the hospital to keep you safe. So that's another barrier over here in the US. If it's a mom with a new baby, CPS can get involved, Child Protective Services, and can take the baby. So there are lots of barriers. I mean, it's as my mentor likes to say, it's not a perfect thing. I mean, even with the best tools, we really cannot predict suicide, but we just have to try our best. And it's a way, sometimes it's the way you ask the question. It's just your patience, how much the patient trusts you. So I agree. It is extremely challenging across the board. And I do women's mental health. So I work with pregnant and postpartum women. It is very difficult to, it's a question that one of our community collaborators asked. Moms are marking them all as zero, but I know they're depressed. How do I get them to talk about it? So sometimes we train people in motivational interviewing, and sometimes I phrase the question differently, I phrase it by almost like giving it a normalized by almost normalizing it. For example, I could ask a question like that, it's been really, really stressful for a lot of people with the pandemic and the financial issues. And a lot of people have been feeling like, things would be so much better if I were dead. Have you been experiencing anything like that? So depending on who I'm working with, I would just phrase it a little different, and I would bring it in the context that you are not alone. There are a lot of people, and how can I help you feel better, kind of thing. So, and then we go to the next step, right? Oh, the patient starts opening up, and then you go to the next step. But it is extremely challenging. What I would say is that you need time and patience and funding. So. Well, thank you, everyone. Any more questions? I'm happy. Again, you can, if you have any more questions, you can always, you can always reach out to me. I didn't put my contact information, but I'm sure you can find it from anybody. But yeah, and if you have any thoughts and suggestions, I'm always open to it. Like Madhu said, Madhu pointed out, 90 is great, but I say it's not great. Let's get to 100%. So if you have any thoughts and suggestions, do feel free to send it to me.
Yeah, surely you can send us the question and we'll divert the question to Dr. Seetha, or we'll make some arrangements where the question can be answered by Dr. Seetha. Thank you, Dr. Seetha, for a wonderful and informative session. And it was really a good session for the people working in the field of mental health, and especially in the research, because all the stats and all the data that you are giving and you're talking about would be related exactly the things that we are doing in the field. There are some difference for like the implementation program there and certain things that have been doing in India. So obviously we can learn, we learn certain things from a new presentation. So thank you for the wonderful session. I'm sure that this will not only help the people working in the area of suicide prevention, but also across the fraternity or as mental health, and it will benefit everyone. Thank you for people who joined us late evening, like at the 4 p.m. when the office hour is about to end. So they also joined the session and made the session successful. Thank you, everyone. And thank you again, Dr. Seetha, for this wonderful session.
Well, thank you. I just have one last comment. If you're doing suicide prevention, make sure you take care of yourself. So we put together those as well, where staff get together and talk about it. So it's difficult work. So I can see all of you are doing it, but it's extremely difficult work and it can affect your mental health as well. So make sure you have small groups. So we did that. Well, thank you. It was a great pleasure. Hope you all have a wonderful evening. I'm going to start my day now. See you.
Yeah, you have a nice day and wonderful day, and everybody have a good evening.
Bye-bye.